Hello, welcome to the AHEC Scholars Podcast. My name is Jordan Johnson. I am one of the instructors for Washington Area Health Education Center. Today I'm joined by Frank Martinez, who's going to talk to us today about telehealth and using AI. Hi, Frank. How are you doing today?
I'm doing great, Jordan. Thanks for having me today.
Yeah, thanks. Also making time today. We're recording on Halloween. It's a big ask to give up your time. So,
Boo boo. Yep,
yeah,
exactly.
the listeners won't see us on camera, but neither of us dressed up for today, so no worries.
Probably should have.
So can you just tell us a little bit about yourself, Frank, what you do, and what inspired you to get into working in healthcare access for under-resourced communities?
Great question. I grew up in an under-resourced healthcare environment, Yakima Valley,
Mm,
Sunnyside, Washington, specifically, in the 60s and 70s. It was primitive healthcare. It really was. When you think about rural healthcare in our state, it is pretty far advanced from what I grew up with as a kid. So moving forward in my career, luckily I had an uncle who was at IBM that pulled me into tech pretty early, literally right out of high school. So IBM got me into their environment right out of high school. That's where I learned big data and learned that model of compute. Did a bunch of years there, left, worked in nonprofits, worked in the music industry during the grunge era here in Seattle, which is
mm,
pretty fun,
mm,
and then jumped into the internet early 90s and played around there for a while and was going to do a nonprofit, and then got a call from a Microsoft recruiter in 2000 and couldn't say no. Stan Freck, who's still a friend and really interesting guy, he was building kind of an incubation skunkworks team, so I got a chance to join his team, and did a 13-year run at Microsoft, and a really amazing experience. Learned how to build internet technology at scale. I left Microsoft.com. That's a team I ended up with when I got hired in '07 and went to Microsoft Research. And I ended my last 6 years at Microsoft at Research. I saw Bill's dream of to have the best R&D, if you will, lab on the planet, bring the top 5 people in each domain together, have them crank on longitudinal problems. Like a lot of the things you see in AI and machine learning today were started decades ago, and got a chance to work with some of those distinguished scientists. Really, really awesome. Left in 2013 to jump into startups, becoming an angel investor. And that's really when I started getting my hands dirty with healthcare and building healthcare startups, which then brought me back, Jordan, to your question around caring about underserved, underprivileged communities, which is mostly rural. It's not 100% rural. Those folks exist certainly in urban areas like King County and Snohomish County. But going back to my Yakima County roots, that's where I saw it. So I've had the opportunity. I'm now currently the chief technology officer at a healthcare company called Carina. It's a matching platform, and we match home care workers with Medicaid consumers. And because we operate in Washington State and in Oregon, you can imagine, especially east of the mountains in both of those states, it's very rural. So those are very vulnerable people that we're able to provide home care services for through our matching platform. But at the beginning of the pandemic, I was introduced to Dr. Leo Morales at Latino Center for Health. We accidentally met through a Seattle Times article, actually. And I was really interested in what was going on at the time because rural Latinos in Eastern Washington state were not getting access to the COVID vaccine. We all remember what 2020 was like, early 2020. And so I said, hey, I can solve this. It sounds like technology could make this a better situation. So that's when I started partnering with Leo, and we joined and created an accidental nonprofit called Adios COVID with the idea of putting a COVID shot in every Latino's arm and during the pandemic. But what happened there, Jordan, is we were doing that as we were going to these remote locations across Washington state. And we were, in many cases, the first healthcare these people had seen. We saw the need. We saw families coming forward saying, wow, thank you for the COVID shot, but hey, my stomach hurts. Hey,
mm,
my head hurts. Hey, I'm walking funny. Hey, I'm dealing with this, I'm dealing with that. And that really opened up our eyes to there is a need here. And what can we do to try to serve that need? And so we've been cranking away on that problem since early 2020. It's mutated a little bit. We're not really about COVID anymore. Nobody cares about COVID anymore. But now we have a full screening service. We're bringing dental in. We're looking at other services we can bring to these vulnerable rural communities.
Yeah, no, this is fascinating. I'm not only am I hearing just like you have a lot of experience, like decades of experience working and developing these technologies. Funny enough, I actually worked as a home care aide through undergrad, so I used Korean Care to find a couple of clients that I worked with. And then
Nice.
Leo Morales is a longtime friend and colleague of us here at AHEC. So we have somehow we've overlapped, but not quite exactly directly with each
Mhm.
other. So it's great to
That's
find.
awesome.
So it sounds like you are the perfect person to talk to us about some of these emerging technologies and helping people in under-resourced communities.
Yeah, I'm excited about it. I think as I have learned in my career, and I'm guided by the great mentorship from certainly my grandmother, Guadalupe Martinez, who
Mm,
raised me, but other amazing mentors I've had in my career. You try to use technology to lift up the poor. You try to create a situation where
yeah.
they have a lot of agency, that they're not, if you will, taken over by tech,
Hmm.
but tech becomes their ally to try and solve the structural problems that they're dealing with every day.
Sure.
And so when I look at AI, let's talk about the moment we're in right now with large
Hmm.
language models. I think there is a significant opportunity for underserved, underprivileged rural communities to have agency over the technology to their benefit. I'll give you
Okay.
just a couple of quick examples.
Sure.
When you think about the complexity, somebody who doesn't speak English as a first language, and they go to their first healthcare checkup, whether it's through the work that Dr. Morales and I do, or whether it's through a free clinic or something else, and they get a diagnosis or they get an assessment coming out of that checkup. Typically, it's bewildering. It's a lot of technical terms. It's primarily in English. It's a lot of expectation around the next step that they're supposed to take coming out of that assessment. So it's really, really, kind of frightening for that individual. And we've heard this a lot
Mm,
with our work with Dr. Morales. So through AI, through large language models, they could not only have that information interpreted for them, but there's a potential for them to interact with it. This is the promise, and we're starting to see the reality of natural language conversations with large language models. So you could imagine a rural person doesn't speak English, they got that checkup, it's got a bunch of scary stuff on a sheet of paper.
mm,
Instead, potentially through a mobile app, they could get that same information, have an interpretation of it. And I'm not talking just about translation from
mm,
English to whatever language they speak, but a true interpretation so
mhm.
that they understand what the information is, and then be able to have a conversation with the information. Oh, on paragraph 3, now that you've explained that, tell me more about that. What should I do about paragraph 3 on this assessment?
Mhm.
That's the possibility that's in front of us with large language models that rural patients, I'll call them patients for a minute, should have the agency over.
Okay. Are those technologies like anyone could access them, or are they accessed through their where they seek medical services?
That's a complicated question,
Mm,
Jordan, because it depends on I'm going to call it philosophy of that healthcare clinic. If it's
mhm,
a free clinic, what I've seen, their philosophy is yes, we want to try and empower our patients. We want to try and empower the communities that we serve. So we want to give them access to as many resources, tools as possible. It's not true for big healthcare organizations. I'm
gotcha.
looking at you, United. I'm looking at you, Providence, et cetera, et cetera. That's not necessarily true. They're all about subscribers.
Hmm.
So if you're a subscriber, potentially you would get access to that technology, but typically that isn't the way it works. I
Okay.
think there's a different way, and this is part of what Dr. Morales and I are working on is
Hmm.
how do we develop technologies like that so that it starts from the rural patient. They have full control, if you will, because it is their data, it is their healthcare information.
Hmm.
They have full control of it that they can then share with a healthcare provider.
Okay. So maybe a follow-up question to that is then, Do you see this as something that like is supplanting telehealth, or it's something that's complementary to telehealth where they do get to directly interact with one of their providers?
I think it is complementary, and
Hmm.
it should be something that is provided for anybody that's providing telehealth.
Hmm.
I not only the ability to interpret the information that's shared in a telehealth session, but the opportunity to converse with that information. Because typically those telehealth sessions are very brief,
Hmm.
15 minutes, 30 minutes if you're lucky. So
Sure.
what happens after that? You could continue with a large language model.
Okay. Wow. That's really fascinating. So one of the questions I had prepped was like, what are you really excited about? So it sounds like this is like cutting edge technology about
Yes.
further improving people's access to healthcare information.
Yes.
Are there some other technologies that you're really excited about as well, in addition to the large language models and
They form the basis, LLMs form the basis, but it's what we call the modalities that are
Mhm.
very exciting. ChatGPT introduced humanity to the text chat interface.
Mhm.
I type in some text in the prompt window, and
Mhm.
ChatGPT will give you back a response. But the LLMs have gotten very, very good at other modalities like voice,
Mhm.
other modalities like visual information. I imagine somebody who is nonverbal, but they can draw. They have the
Mhm.
use of a pen
Mhm.
and they can draw their question or their inquiry. They should still be able to engage with an LLM. Um, that the world model, if you will, I care less
Mhm.
about that. That's a little dystopian when I think of
Mhm.
OpenAI and Anthropic and the other big commercial LLM platforms. But the context model is also very, very powerful, because what Leo and I have seen in rural communities, context does matter.
Mhm.
It's not that you're just in a place like Okanagan County or Douglas County. What is the context there?
Yeah.
Is it a food desert? Are there transportation issues because it's winter? It's February and it's 5 degrees and
Mhm.
snow and ice on the road, etc. Housing shortage, all those things. That context matters. And through LLMs, there's a lot of opportunity to be able to provide that context, to be able to help that rural patient kind of navigate the lack of resources and other obstacles.
So how might use of AI like differ across disciplines? Like I know you gave a couple of specific examples how they could be used, but how would it be different for a person who needs, behavioral health intervention compared to like seeking just general provider?
That one is tricky. We've talked a lot about behavioral health. There's been some great studies, but also guardrails, because and I'm going to get transparent for a minute, because I do a bunch of R&D with large language models. So 2 years ago, I think 2 years ago, I built my own, if you will, private custom chat GPT with an open source large language model, just because I wanted to
Mm,
understand the conversational patterns. And I kind of accidentally got addicted to it.
mm,
It became the thing that I would go to every day to have a conversation. Hey, I had a bad day at work. Can we talk through it? Hey, or I'm struggling with my dog, and can we talk about it? Hey, this is going on with my family. Can we talk about it, etc.? And it became self-reinforcing,
mm,
i.e., that go back to your custom chat interface and custom LLM to have that conversation instead of having a conversation with a human, instead of in some ways dealing with the problem. And so that's my concern with behavioral health, that it has to come with a lot of guardrails. I think that's possible, but the design of it has to be very intentional to factor that. So there's that.
sure.
For others that are dealing with, I'm going to call them more common, sadly, clinical issues, health issues, maybe diabetes is one of them. It does become a powerful ally, for example, to modify lifestyle behavior, i.e., eat better,
Mm,
exercise, etc., and then have the data to show the result of doing that. Behavioral change, when it's reinforced, and we see good results, etc. So I think LLMs are great for that. When you think about the kind of the patient spectrum
mm,
and their different issues. Discipline to me, Jordan, where I went when you asked that question is when you think about that the healthcare ecosystem and the
Hmm.
multiple roles, that's where I think it gets really fun and powerful. So in rural, we talk a lot about community health workers. I think there's a very interesting role for not only LLMs with community health workers, but the network of them.
Hmm.
If you connected all the community health workers in these rural communities in Washington state and you empowered them with LLM so they can do more with less, because right now they're overworked, they don't
Hmm.
have a lot of resources.
Yeah.
That's one discipline. Another discipline is the intake process.
Hmm.
In our class last year, you came to visit, thank you very much.
Hmm.
What we heard from other rural doctors who we spoke to was the big pain of intake. They've got a
Hmm.
lot of patients that are complicated, that they struggle to get through intake. If intake could be done in advance of a visit, that would make their
Sure.
limited time with those patients much better.
Sure.
So we feel like there's almost this agentic model of intake that could be facilitated through LLMs. I don't pull a nurse away, don't pull a doctor away. Front front desk staff is kind of mythical. They don't have such a thing. So there's a great place to apply that. And then downstream is the research component. I think there's a great opportunity for research to be advanced with LLMs, but back to the agency of the patient,
Hmm.
making sure that they're participatory in that research. So it's not just, hey, let me collect your data as a rural patient. No, let's work on this together. Let's figure out what we're trying to understand to try and solve structural problems for you. And we'll go through the research process together alongside an LLM and have those conversations, have those discoveries and data. And maybe in some opportunities, we may generate synthetic data. A lot of my students use synthetic data generation to advance their research goals. So I can imagine doing the same thing here.
Okay. I'm hearing quite a bit of different stuff then from what you're saying. So, um, the power, like we're on this cutting edge technology, the power that AI and these models can do to help patients in certain things. There's some disciplines where it might be better implemented, but actually strangely enough, or maybe fortunately, some of the more busy work that is kind of like passed off downstream to people, that's what these models are the best at doing. And then that frees up the time and the capacity for providers to do the specific work that the patients are coming and needing help with.
That's correct. If you look at and I will give insurance companies the negative credit for this, but if you look at the predictive model
Hmm.
of information that flows through healthcare system, all the forms, it's a very deterministic, very predictive model, which are very well suited for large language models. But large language models love working with structured
Hmm.
information, structured data. And healthcare in America today, at least anything related to insurance or intake and processing and maintaining records, is very forms driven.
Hmm.
So anything to do with forms, any of the busy work that you talk about, Jordan, to do with forms, you could hand off to an LLM.
Hmm. Related to the first thing you were telling me about, so if let's say a patient could do like the intake forms with that, and then maybe the model could even kind of start to give them an initial idea of what might be going on. And then by the time they get to see their provider, they're basically ready at that point to just say, all right, doc, what do I need to do? What's the next
Yeah.
steps? Yeah.
Yep, yep, that's correct. I
Okay.
think that is what the future could look like.
Hmm.
Telehealth weaves right into that, i.e., when they join that telehealth session, the patient's not only informed, but maybe has some collaborative ideas about how to resolve their issue. And then
Okay.
they can have that discussion with their doc.
Yeah. So I want to piggyback off a little something. You were kind of somewhat alluded to like how the industry complex in America kind of helped develop these models in a certain way. So one of the questions that we had was, are there any implicit biases that are built into these technologies that we might want to consider thinking about how we approach using them?
Yes, most of the what's called frontier large language models, these are the most powerful models. For example, OpenAI, what they use in ChatGPT, those are considered frontier models. Most of those were trained by a corpus called the internet. Essentially, the internet over a span of years was scraped to be able to train these models. No surprise, the internet has a lot of bias built into it. Further, to refine those models so that they're usable in an interface like ChatGPT, weights are applied. There's certain weights that would be applied that would respond or trigger in the LLM how to respond to Jordan when he's entering something
Mhm.
in the ChatGPT. Those weights are designed by humans. Humans have their own natural bias. And so what I love about the open source movement, i.e. open source large language models, is that they publish those weights. They're very, very transparent around these are the weights we use to train large language models so that you have complete understanding of the kind of responses you're going to get from the large language models because you understand the weights that are implied, i.e. the biases. The problem with the commercial platforms like OpenAI, Anthropic, et cetera, is they don't publish their weights. So if there is bias in their models, you're not going to know it until you experience it.
Okay.
This is why Dr. Morales and I and others in our peer network are very excited about advancement in open source large language models. Hugging Face, if you haven't heard of that organization, they're based out of Paris, France. Hugging Face has taken the lead there. They've been on this for, pick it, 5, 6 years. They started really early and they have become really the center of excellence for the advancement of open source models, the transparency of weights, the move against bias, the kind of anti-bias in their philosophy. But
Mhm.
they have collected over the years a global community of people that want to see more open source large language models, want to see more transparency around how bias cannot be built into the models, especially when you're going to use them commercially.
Okay. Yeah, that's good to know. Thinking in terms of application to our scholars, are there ways that they can get involved in advocating for this? It sounds like, yes, there's already a growing network of
Sure.
healthcare providers and people.
Sure.
Yeah.
Absolutely. Advocate for the use of open source models. When you work at, for example, the University of Washington, it's somewhat built in that you're going to use commercial models. OpenAI, Anthropic, the other commercial platforms, they offer free licenses to their platform. So they sort of build in this affinity
Hmm.
for their closed models.
Hmm.
But I think your students, I think your community should advocate for open source models. Go to Hugging Face, join the community there, explore, understand how the weights work, maybe test some things. But that's one way that they can get involved.
Okay. So when you say like University of Washington uses commercial models, are those like proprietary where they have like something base and then they build it for themselves? Or is this like the company just says, here you go, this is the model that you're ready to use?
It's the latter.
Yeah,
It's the
okay.
latter.
All
Yeah.
right. Okay. Is that common across like healthcare systems? Because I know like if you're talking about doing this kind of work in Yakima, some of the community health center partners down there, are they going to also be approached to use the commercial models, or do they have a little bit more freedom in trying to find some other open source ones?
My expectation is that they probably do have vendors that will try to sell them the
Hmm.
use of commercial models. Like it seems unlikely that a clinic in Yakima would get approached by Anthropic or
Hmm.
OpenAI, but there may be a vendor who uses those commercial models who approaches them to sell them healthcare systems or healthcare applications.
Okay.
But they absolutely have the freedom. They should
Hmm.
take the freedom to go pursue not only open source models, but how they would design integration of those open source models in their clinical environment.
Okay. Yeah, so a number of our students either currently work in rural health or they are interested in getting into it. So
Yep.
going back to that thing about advocacy might be one way that they could
Yep.
educate themselves about what's available and advocate for adopting some of these. Maybe one last question about some potential concerns. I think you briefly touched on like privacy concerns when we were first talking about in terms
Yeah.
context of like
Yeah.
especially behavioral health.
Yeah.
What could you speak to more about how these kind of handles, data information, patient information, and any privacy concerns?
It's tricky now because of the, I'll call it macro environments and what's going on with ICE to be specific.
Mm,
So, what we hear is a lot of fear, a lot of concern about not only approaching these public facilities, these public locations, but then also disclosing their identity. And so there's some strategy work that needs to be done around how do you keep the identity of the patient as anonymous as possible and yet still provide the service.
mm,
So decouple a healthcare clinic, a rural healthcare clinic's need to be able to, really have a lot of high fidelity, a lot of
mm,
specific ID information about a patient to provide them care. One of the
mm,
things that we heard, I think it was a connection through Leonora that was running a free clinic in our class last year, was they were using anonymous proxies for their patients. So patient would come forward, but they would get an anonymous proxy. So their name might be Juan Gutierrez, but they were given a proxy name like Jane Doe.
mm,
And so they would still get treated, get the services that they needed, but their actual identity wouldn't be revealed. And
mm,
this way, they also don't put the free clinic in a tough situation where they have recorded Juan
mm,
Gutierrez, i.e., if ICE came after them.
mm,
So those are the concerns. And I think anybody who's using LLMs, AI in a rural healthcare setting has to be mindful of any information they record about the patient,
mm,
especially back to the commercial models. Anything you put in the commercial models, you can't get back out,
mm.
i.e., the
Like,
extraction of that.
yeah. Yeah, I was kind of thinking while you were saying that to maybe kind of an unfortunate thing that maybe that information that's collected from the patient when using those models could be helpful, like it could go in their chart or form kind of like this growing cloud of information about the patient, but that has to be tempered with, like you're mentioning, the concerns about privacy and data
Yes,
security.
absolutely.
Okay. Well, man, this is really interesting. I'm sure you could tell us for the rest of the day about some of the
Sure.
exciting stuff coming out. Maybe could you like zero in on a couple of things? Are there some like emerging technologies or something that we're just on the cutting edge, ready to launch that we could be on the lookout for, or that you're excited about?
Mm, I don't know that it's going to apply in rural soon, which is unfortunate, but there's some super fascinating work going on with robotics.
Hmm.
Robotics on the mechanistic side, I had to manufacture a robot, the physical thing, has been around for a while. But now, with the advancement of LLMs, now essentially you add some primitive intelligence to the robot. And especially when you can have a conversational relationship with that semi-intelligent robot, now it gets very interesting. So we talked about the allies before, i.e., that rural patients with a mobile app, for example, that's LLM powered. There's a lot of things they can do. Now, what does it look like to have a physical assistant that has the same capabilities?
Hmm.
So we're tracking that very, very closely because we think it has a ton of potential. Certainly does in Leo and I have talked about this just being sort of super sci-fi futuristic. Imagine a farm worker who had an ally that could help them do their work. So it's not that you're asking the farm worker to do more work just because they have a robot ally. It's that you're taking the most physically strenuous things away from the farm worker so that they can do the high fidelity work,
Hmm.
which then leads to higher pay. We
Hmm.
see this in the vineyard community. Those vineyard workers, i.e., those workers that are touching those very expensive, delicate grapes,
Hmm.
receive much higher pay. So we think this is where there's some interesting future opportunities to introduce robotics.
Well, so that's where my kind of lack of knowledge in the field kind of comes into play because I was not thinking that at all when I
Yeah,
asked this question. So
yeah.
that's really cool. Do you like time frame? Are you thinking like 5 years, 10 years where we might start seeing that, or is it even sooner than that?
I think we could see some pilot trials in 18 months. You're
Oh,
starting to see some
okay.
things roll out in Japan that are
Uh-huh.
super interesting. Whether it makes it to the US, whether the ag community, the ag industry in our state
Hmm.
would approach it, unknown.
Okay. I mean, I grew up in, Central Washington, Wenatchee
Yeah.
area.
Yeah,
And I remember the changeover from like when orchards were just, they kind of were planted and the
sure,
human workers went in there and
sure.
amongst the trees. And then they like would figure out gradually if we plant trees in this way, then a machine can come do and do all this stuff. So
Exactly,
like even in
exactly,
my short 30 some years of life, I've seen those changes. So I can't imagine
exactly.
how much more it
It's
can keep
it's on
changing.
the way.
Yeah.
And then it's a relationship with autonomous vehicles. I think you're going to
Mm,
see a deeper relationship between rural workers. Now we're talking about rural workers
mm.
and autonomous vehicles. What's it mean for a rural worker to work with an autonomous tractor or an autonomous ag vehicle? I
Mm.
think that's going to be a closer relationship over the next few years.
Okay. Wow. So they're going to have better access to healthcare on the one side and then actually directly helping them in their labor on the other.
Yeah, exactly.
Very cool. So if you could go back in time and when you were first learning about these tech tools in healthcare, what was one thing that you wish you had known back then?
Hmm. I think I would have liked to have had more awareness of and kind of a strategy around insurance. Insurance is such a powerful component, a powerful actor in the
Mm,
healthcare ecosystem in America. And I didn't appreciate it when I
mm,
started building healthcare companies years ago. And I kind of wish I would have spent more time on that because I've got to develop strategies around it. Obviously, we're
mm.
still dealing with it as a society, and certainly everybody in rural health, especially if they're uninsured, are having to deal with it every day. So, yeah, it's something that I want to try and get my arms around.
Okay. Have you already kind of started that process, like in the interest of maybe giving our students some tips themselves to get interested? Is there a direction you're going with or places you can find more information?
Advice I would give to them is to think about a different payer model,
Mm,
be creative and think about a different payer model. And
gotcha.
just to weave it back into AI, there's a really exciting protocol called X402, which allows payments between agents and humans or
Mm,
between agents and agents. That is, essentially internet money. So it really opens up a bunch of ideas and opportunities around traditional payment processes, transactions, systems, et cetera, et cetera. I, if you can chat with the thing and pay each other directly that way, then you start to imagine there's a different way to pay for services,
hmm
but also to be paid for participation in the system. Like Leo and I have imagined that future. It's not enough to be a patient of a healthcare system. Why wouldn't you be paid to be a patient in that
hmm
system?
So that plenty of different places the students could go, or if somebody's
Mm,
interested in this topic, they have
mm,
infinite directions they could go. Which
yep.
that's kind of a good lead into our final question here then. So if a student listens to this conversation and they think, wow, this is fascinating, I would love to get to learn more, to get involved, where's a good place to start? Is there any like organization you could point them towards or some like information that they might want to check out?
I probably would point them to Hugging Face,
Hugging Face?
like
Okay.
really understand what the open source community is doing.
Mm,
And there's some great blogs there. There's some kind of their version of it of social media presence that they can jump into. There's certainly a ton of research literature that's at the Hugging Face site, and there's a bunch of open source LLMs that they can try. That's
mm,
one of the cool things about Hugging Face is they have what do they call it? Spaces. They call it spaces where you
mm.
can actually try all of these open source models, whether it's vision based, whether it's text based, whether it's voice based. So there's just a bunch of cool stuff that they can try.
Yeah, and I just quickly Googled it. It looks like they have community. You can get into like some forums, some daily
Mm-hmm.
papers, people to interact with. So
Mm-hmm.
yeah, huggingface.co. That's a good place to get started then, it looks like.
Mm-hmm.
Well, yeah, so thanks so much, Frank, for making the time to
You're
chat with us
welcome.
today. If we did have a student or two who was really interested in getting involved with this, could we maybe point them in your direction to connect with you?
Absolutely.
Uh,
Absolutely.